Hi, my name is Kimberly Trammell. I am a graduate nursing student at Maryville University in the Family Nurse Practitioner program. This is my patient, Taylor. She's a 17-year-old African-American female. I have already conducted hand hygiene and introduced myself. We're going to be doing a cardiac physical assessment, and we're just going to jump right in. All right, first thing I'm going to do is inspect Taylor while she's sitting up. As you can see, her skin is clear. There's no signs of previous surgeries. She has adequate capillary refills, nice pulse. Her skin is in line with her ethnicity. There's no sign of cyanosis around her mouth area or her hands. Her fingers do not show signs of clubbing. She shows like she has good blood flow return. All right, now I'm going to have her lay supine. Taylor, can you lay back here? In a normal situation, we'd be on a bed. Again, continue with inspections, looking at for any jugular vein distension. She is a thinner person, so you can clearly see her pulse right now. Looking at her carotid pulses. I will palpate for those later, making sure not to do them both at the same time. So now we're going to palpate. In a normal cardiac physical assessment, she'd have on a gown and she would not have on a sports bra, so I'd have more skin-on-skin contact. Feeling for any crepitus. Any pain or discomfort? What we're looking for is feeling for her apical pulse, which is usually 5th intercostal, about mid-clavicular line. And again, this would be more on the skin. She is a thinner person, so you can feel her. This is her point of maximum impulse. Nice and strong and steady. All right, so we've palpated. There's no, I didn't feel any thrills or, let's see, lifts. She, so far, physical exam has been normal. So we've inspected, we have palpated, and now we're going to percuss. And percussing, we're going to be outlining, trying to outline or estimate the shape of the heart, and that's done by simple tapping. All right, I'm going to be tapping right here. And we're listening for changes in dullness and resonance. All right, now we're going to auscultate. I have my stethoscope, and we're going to start right here around her 2nd intercostal space, listening for an aortic sound. And this would be for a full cardiac cycles to get a good, really good glimpse. We'll move over to the pulmonary valve sound. Second pulmonary area. Tricuspid. And then in the 5th intercostal, about mid-clavicular, the apex sound. If I was having difficulty hearing her apical sound, I could turn her on her left side and have her lay left recumbent, which brings the apex closer to the surface of the skin. Lay back on your back. But she's, I can clearly hear her apex. I would then, during the listening sound, we're listening for any signs of murmurs, friction, pericardial friction, any type of her S1, which is her systolic beat. I would palpate that simultaneously with her carotid while listening. We'll go right here. And again, you actually can even see her carotid artery. and it is actually, the S1 is simultaneously with what I'm hearing in her pulmonic area. Her S2 sound would be her diastolics beat, and she is has a good, based on her history that I know, she has a good heart history, and she has a strong S1, S2. I was not able to hear her S3 and S4, which is normal, but she has a nice, strong lub-dub sound, which is all normal findings. So I would consider this to be a normal cardiac physical assessment. And that concludes my cardiac exam.